So just a little introduction to our team here that cover Cheshire and Mersey. We're actually based and hosted by Liverpool Heart and Chest Hospital and supported by the Innovation Agency also. We are led by our consultant lead, Dr. Shirley Bowles, who sadly can't be with us this evening, a wonderful colleague, Julia Finch, who has a huge experience in genetic testing, our administrative support, Faye, who can't be here this evening, and we have another new member just recently, Jolie, also. So the service is basically a pilot service that was introduced in April last year and should have ran until April this year, 23. Fortunately, we did receive some further funding, and at the moment we are in place until December this year. There has been a recent flurry of activity in submitting a business case in the hope that the service can continue long term, but obviously with resources so short in the NHS at the moment, that remains to be seen, but hopefully it will continue. So we have a little map of our region here, so it's quite a vast area that we're trying to cover with a very small team, like most services in the NHS. So we were brought into post to try to identify and support clinicians identifying people within our area, as Marie has pointed out, the different ways to try and identify and refer patients into services. So in Cheshire and Mersey alone, it's estimated that there are approximately 10,000 patients affected with FH. So around about 1 in 250 people. And therefore, we would need to test approximately 2% of the population to detect all of these cases. And as we all know, it's much easier said than done, especially when clinicians and clinics are so busy with so many different goals and tasks to achieve. So Marie has kindly talked about different processes for referring patients into local FH lipid services. Again, I think, we have these risk assessments and so on, and different forms that we can complete, and different search tools that are available out there, which obviously take time from a busy clinician. But I think, considering that we're trying to cast the net a lot wider, looking at more and more young people, I think sometimes there are very small telltale signs or opportunities for red flags. So the pictures that I'm going to show you now, it doesn't necessarily mean that every individual with these clinical symptoms will definitely have FH. But for a busy clinician, I think, as I say, it should be a red flag to actually consider, should this person be tested or referred for genetic testing. So we have the tendon exanthoma, which we can see the lumps to the heel there or onto the knuckles as well, which can be an indicator of FH. As we say, not in every single case, but it's certainly a clinical symptom that shouldn't be ignored. This bottom picture here, this is actually of a case of a heterozygous, so the very rare FH, and you can see how extensive those deposits are. So as we say, we're just taking the opportunity here to highlight to busy clinicians who have lots of patients coming through the doors. We also have the xanthelasma, which are these little yellow deposits often found around the eye area. So again, the likes of this should definitely be alarm bells for any patient really, but particularly patients who don't necessarily tick all the boxes, or when we do a risk score, that they may not currently have any family history of heart problems, but that does not mean that they should be overlooked. Similarly, with the corneal arcus, so on here, it's suggesting to be suspicious if a corneal arcus, which is the grey-white circle, is found in a younger person. It says 40 years, or anyone up to 45 years really is classed as premature. Now, this can be a really important clinical finding. Again, it doesn't always definitely mean FH, but equally it can be an absolute sign. And we have several patients on our books at the moment who've been referred following optician review. So some very keen opticians out there who quite rightly followed these findings up. Okay. So again, just to cover what Marie mentioned before about the case finding and the search tools available in practices. Many practices are using these tools extremely well, particularly with the assistance of the pharmacists. Pharmacists are playing a huge role in case finding. In our experience in Cheshire and Mersey, we've built up a lot of rapport with a lot of them, and we're very grateful to them. So case finding and search tools is definitely a huge pathway into referring patients to us. Equally, if the patient does meet the criteria with the Dutch lipid score or even the referral form for the Cheshire and Mersey service, they can obviously be seen then. But again, we try to have a user-friendly, flexible approach. If there's a patient who, for whatever reason, doesn't quite tick all the boxes, but a clinician has alarm bells ringing, by all means, contact our services. I'm sure Marie would agree with that. We will absolutely discuss any individual, even if we feel they're not actually, meeting every criteria tick box. We would rather consider someone than rule them out prematurely. So as Marie has kindly mentioned, an individual referred to the service then undergoes the genetic testing and is confirmed to have a genetic variant. Their immediate first-line relatives are automatically entitled to join our service as well. So in the Cheshire and Mersey service, we will provide a relatives letter, and that kindly invites the relatives to contact us. Because of data protection and other guidance, we cannot contact those other relatives because obviously, as we say, because of confidentiality. But we try to remove the barriers of other relatives having to be referred by a GP or specialist consultant. So we try to have an easy access system to encourage them to come along to the service rather than avoid it. So again, just recapping the recognition of trying to find these individuals and not assuming that, people who are so young won't have any issues with cholesterol and certainly won't have any possibility of FH. We are definitely trying to turn a corner with that. And also once an individual does have confirmation of DNA genetic testing, absolutely encouraging as many of their first degree relatives as possible to come through for testing with us. Now, again, as we speak to individual patients and to clinicians, we should use our wording wisely, because some people do think, third, fourth, fifth generation relatives and so on may be open to genetic testing, but it really should be the first degree relatives, and then depending on the results from there, down to other relatives and children and so on, which, as Marie quite rightly said, is what we call the cascade testing. So for every patient who is accepted into our service and has an appointment and goes on for genetic testing, during the clinical consultation, we do undergo past medical history and lifestyle advice as well. And this is particularly important for all patients, regardless of whether they have the genetic variant confirmed or not, because at least this way we have taken the opportunity to have a health check with them and making every contact count as well. So even if it is found that they do not have a genetic variant, we've still had the opportunity to discuss lifestyle factors with them. So particularly if an individual is confirmed with a genetic variant, then the high intensity statins should be either commenced or reviewed and titrated until we achieve that reduction in the LDL level of at least 50%. So again, some patients referred to the service may not actually be on medication when they are first referred. And of course, this is subject to change depending on the results. But again, it's another good opportunity because some patients who, after testing, are confirmed that they don't have a genetic variant, they do still have the high cholesterol that still needs managing. So never a wasted opportunity. Okay, so as Marie kindly mentioned, I'm going to talk you through one of our families, one of our case studies, and I do apologise. I know that the wording is rather small on this, so I will try to talk you through it if that's okay. So basically, this family started with patient one. Very sadly, a young man, aged 29, who had been told he had raised cholesterol, didn't actually get the opportunity to then follow that up and start medication, and sadly did pass away from a heart attack, as we say, at the age of 29. And it was afterwards that he was found to have extensive coronary artery disease, which then prompted his other relatives to come forward. So if we look to the left to patient two, this was out of this whole family, this was the first patient that actually presented to us. So he was referred by a lipidologist. So again, was very young when he was referred with high cholesterol. So we put him forward and he underwent the genetic testing and was found to have the very common variant of the LDLR. So this was useful for the patient because thankfully he was being monitored and reviewed with his lipid medication anyway, but because of his genetic findings, other people in his family then came forward to us for testing as well. So we have his sister came forward, so patient number 3, and if we remember, these are all young people, late 20s, early 30s. So patient number 3 came forward, and this lady was actually trying to undergo IVF, obviously for pregnancy, and had various concerns and issues over taking lipid-lowering therapy whilst planning for pregnancy. So again, she tapped into our FH service, had counselling with my colleague Julia, and then was much better placed to make various decisions. And then she actually halted her therapy, her lipid-lowering therapy, while she's trying to conceive. And she has a lot of support, both from the FH team and our lipid lead consultant also. So this then brings us, if we look above, we can see patient 4, which is their mother. Now, at the time when her son passed away, patient 1, mum was actually diagnosed with very high cholesterol, but didn't come forward for genetic testing. But it was following the results of her other son and daughter having their genetic results that mum then came forward, and she was also found to have the same family genetic variation of the LDLR. So because obviously this emerging picture, which is why we're showing you this family tree, because it just speaks volumes, mum then had some of her siblings come forward. So we can look at patient 5. So patient 5 was undergoing testing with us, and whilst we were awaiting her results, sadly, her son, patient 6, her son was actually admitted to the local tertiary centre at age 32 with a heart attack and requiring urgent bypass surgery. So this is all within this year, so, you know, recent times and so on. So for a family that already had significant shockwaves circulating through it, this was just another awful event for them. So whilst he was an inpatient, my colleague Julia was fortunate enough to go along and see him and go through the genetic counselling, etc., with him, and she arranged for his genetic testing whilst he was an inpatient. So from a patient perspective, it was almost a one-stop shop, really. So because of his results, and when his results came through, he was also found to have the genetic variant that the family carry. And his son, patient 11, just below there, he is also undergoing testing in the very near future, and he's age 13. So we have that child there as well. Okay. So because of this relative, patient 5, having hair testing, other relatives, patient 8 and patient 9, also came forward for testing. Patient 8 was actually found that they didn't carry the genetic variant of the LDLR. And again, patient 9 was found that they didn't carry the variant. I think it's fair to say at this point, if you look at patient 9 down here, who is the young son of the young gentleman who sadly passed away. So patient 10 has been tested, and he also carries the family genetic variant of the LDLR. So he is currently 11 years old and is on medication. So out of this whole family, just basically at a glance, we can see that 6 out of 11 of them have been tested, and 6 out of 11 of them do carry the genetic variant. So although 2 have been tested and were found not to have the variant, 6 others do have. So it just shows you how powerful the cascade testing of FH services is and can be. And we can now have these people on medication, liaising with either the lipidologists or the GPs, and providing some guidance and support as to titration to obtain optimum reduction in their levels. I think also what's interesting, we keep bringing it back to finding people, much younger now, rather than later in life. So the fact that here we have several children in this family, as I said earlier, one of them has undergone testing, one is about 2, and that basically children normally from the age of 10 can now be prescribed lipid-lowering medications. So that can almost be, it's wonderful that we have that option for families, but again, it can lead obviously to many discussions amongst families, and that will bring us on to our next slide as well. Okay, so as I keep mentioning, one of the takeaway messages from this evening should be that we look younger and younger in people for either high cholesterol or the possibility of FH. And we've been fortunate enough in our service, as I say, to be involved in several working groups. And one of those has been led by both Rosie and Sue Kemsley. And that is to produce a lipid lifespan pathway, which I'll mention a little bit more about in a moment. But the idea is that we basically look at every individual from as early on in life as we can up until as long in life as we can. So everything for primary prevention is obviously getting in there earlier rather than later. So another initiative that's going on across the Cheshire and Mersey region is this child parent screening service, which again is a pilot, but thankfully just recently has been extended for another further 18 months. Now, what this incorporates is that basically when babies go for immunisation checks at 1 year old, they have a heel prick test also. And when the heel prick comes back, if their levels are raised significantly, they will then be put forward for the genetic testing. So if their cholesterol at the heel prick test at age 1 year old is total cholesterol 5.3 and above, they will then have a sample sent to the genetic lab. Now, if it comes back that they are carrying one of the genetic variants for FH, obviously that's for discussion then amongst the family for that cascade screening of both parents and siblings as well. So again, it's wonderful that we have such opportunities nowadays. As we say, children with confirmed FH can be medicated normally from the age of 10 upwards. So across the regions, obviously these children, some of them have been known for some time in these families. And I know here locally, we have the wonderful Professor Joe Blair over at Alder Hey, who's been looking after such children as our lipidologists over on the Wirral and Warrington also. So since we've been in post with the Cheshire and Mersey service, we're obviously trying to link in with these established teams a lot more so that we can have a seamless pathway to manage such children. So going forward, we have just been given the go-ahead in the Cheshire and Mersey service for Julia and I to actually see the children, and we will be doing this remotely via Attend Anywhere appointments with their parents on the appointment with them also. So we shall be doing the initial consultation with the children and the initial genetic counselling, and then arranging for the testing of the children, and then the management will often be overseen by Professor Blair at Alder Hey or other equivalent lipidologists in the area. Some of these children may also be managed by the Manchester service as well, depending on the area that they live in, because some of the boundaries are very close to each other. Okay, so this then brings us on. I mentioned before, there's various projects and pathways being brought together in the region to just make the most of every opportunity to try and prevent people falling through the net who either have high cholesterol and then possibly the FH. So I mentioned before that both Sue and Rosie and many of my colleagues on this call have all given a lot of time and effort to this pathway and this lifespan approach. So as we say, it's either tapping into current appointments and opportunities in the healthcare system that already exist, exactly just like the immunisation for the babies. Let's take the chance to check them for the cholesterol as well. The same for the younger people, 18 to 39, because again, when we're young, we often think, oh, we don't need to worry about our health. It's something we only concern ourselves with when we're old, whatever old may be for different people nowadays. But it's looking at opportunities, for instance, when youngsters go to university and so on, just different opportunities to tap in. So we've come up with various ideas, and as always, some of them sound wonderful when we're sat around a table, but it's actually bringing them into practice, isn't it? But again, for this age group, it may be the likes of when they go for their family planning clinic appointments, and again, eye tests and things like this. So the health checks that have occurred at the age 40 to 74-year-olds, they've been obviously going on for some years, and 75 years and over. So it is looking, if they're not already having cholesterol levels checked there, if the cholesterol levels are significantly raised, rather than just think, well, let's keep them on the medication. It's that constant reminder of, could this person have FH and should they be referred to services? So going forward, what else has been useful in this whole process of devising the lifespan approach is that people on that working group did feel very strongly that although we're going from as early as possible, particularly with lipid medication, there does actually come a time in an individual's life where you do have to weigh up their prognosis, not just of FH and cholesterol, but other perhaps long-term conditions as well. So as clinicians, I think it's also very important for us to remember there may be a time for some individuals where we think actually the lipid lowering medications that they are on, should they continue on those, or, you know, is this time now, if you look at over the next 5, 10 years, etc., what is their prognosis from other things? So it's about having the knowledge to also deprescribe lipid lowering medication in those areas where necessary. Okay. So again, it is difficult out there for very busy clinicians. You have so many things to consider. Equally, to try and help out, there are different guidelines as well now brought about with NICE. So we have the lipid management pathway for primary and secondary prevention. So a lot of it is focused on this 50% reduction in the non-HDL. Now, interestingly, one of the things I would like you to remember if you're considering referring a patient to FH services, our consultant lead, Dr. Shirley Bowles, is very, very strongly concerned that you do not always use the Q risk, because she doesn't always feel that it's accurate. And we do indicate this on our referral form as well. Similarly, we do feel strongly in everyday practice that if an individual is going to have cholesterol tests, a regular lipid profile, we have to keep this in context. So we wouldn't recommend, for instance, someone to have a lipid profile if they've just come back off a 2-week holiday, for instance, or if it's just been the Christmas holiday period and perhaps people are eating and drinking things that they wouldn't normally, or, you know, more excessively. So it's about bearing in mind little factors like that also. Again, I think it's quite difficult out there for busy clinicians when we talk about lipids and, you know, which dose should they be on or which tablet and so on. And we all know there are individuals who do suffer with statin intolerance. And again, this is why this pathway is so useful. And I hope that everybody in the audience is completely familiar with this. I think, you know, statins, as we all know, have had bad publicity over recent years. And that's highly unfortunate. And again, part of our role is to try and support that confidence in patients, and by, you know, reminding them that yes, we do have these pathways. However, for many patients, as we all know, if they are commenced on lower doses of the statins and then just titrated slowly, a lot of patients do tend to fare much better at tolerating on the low doses, or perhaps even alternate day doses. Okay, so this is a slide that I've borrowed from our consultant lead, Dr. Shirley Bowles, and it speaks for itself really about the statistics there for someone who is treated with statins and for someone who isn't. And I mean, you don't need to really say any more looking at that, a 90% reduction if they are treated with statins. You know, it's say no more really. But again, to support this and to support the previous slide of the intolerance with statins, we are very fortunate nowadays that in recent years there's been this whole flurry of new medical therapies available to us out there as clinicians. So we know there are some people who, with the best will in the world, just will not tolerate the statins. So it is wonderful to know that we do have other options available. So this is a bit of an old slide now, and I know that many people in the audience will have seen this before. And it is just, again, another stark picture at how effective different statins are. I know a lot of these statins now are quite old school, we don't see them anymore, but obviously they have been around for a long time, which is why we do have this information about them. So again, that brings us on nicely to the next slide of the newer therapies that are out there. Ezetimibe has been around for some time now, as bempedoic acid has. So we also have these injectables. Now, again, you know, the media had a field day with these injectables, and I hate to point out the Daily Mail, but they did suggest that, all patients could just have an injection and, everything would be hunky-dory. And I know that both in cardiac rehab, in my previous role in the lipid optimization clinic there, we did have patients contacting us asking for this wonderful injection. So obviously we have to use our skills to remind everybody that they don't suit everybody. And, there is a strict criteria before moving on to the injectables as well. So I know that Rosie has kindly included details on this presentation about the previous webinars that have taken place discussing the different therapies also. So I think it's to bring it back to these bullet points for you busy clinicians out there, that, it is overall a 50% reduction in non-HDL or LDL from baseline that we are striving for. If an individual is confirmed with FH, then there may be tighter restrictions again for their LDL, normally often below 1.8. Okay. So we've talked about different ages and the lifespan pathway. I think, again, if we are looking to include younger people even more so, possible FH testing, we do need to remember, and we've had several cases of this, there'll be either a young lady or a couple planning a pregnancy, and they want advice about any side effects of lipid lowering medication. So looking up on this, it is thought that there is a very slight possibility of side effects, particularly the central nervous system. So as a result, anybody absolutely planning a pregnancy, it is recommended that the lipid medication is discontinued for 3 months prior to the pregnancy occurring, and certainly throughout the duration of breastfeeding. So again, this takes some counselling for the lady trying to become pregnant, that, that they need the support of the lipidologist, obstetrician, and they need the reassurance that to stop the lipid medication for that time, for most of them, will be suitable from a cardiovascular perspective as well. So we do know that if a pregnancy does occur unexpectedly whilst a lady is on the lipid lowering medication, then basically they should be reviewed as soon as possible, really, reviewed by the lipidologist and the obstetrician, and after counselling, any other decisions made there. So as much as we've discussed that lipid lowering therapy should be stopped for the most, there are resins out there that allegedly do not enter the placenta, and so can be safely prescribed during pregnancy and breastfeeding. So again, I think from a clinician's point of view, it's useful to know that there are these other options available. But again, that's what the likes of the lipid specialist services, the FH services, Marie, my colleague, and so on, we would happily take any queries or signpost any enquiries on if a clinician wanted us to do so. So we have some links here for the YouTube webinar of the Cheshire and Mersey FH service. So what we have been doing in recent months is we've tried to have monthly online meetings on a Thursday afternoon for practices who we know are extremely busy. So we've just tried to keep it short and minimal at half an hour. So there is that link there for all of you busy clinicians, as and when you ever get time to have a look at that presentation about the FH services. We've also included the Heart UK website. Heart UK, for anyone who doesn't know, is absolutely amazing for information around cholesterol management and FH in particularly. It's just a phenomenal source of information for clinicians and individuals, and it has lots and lots of user-friendly information, little cartoons and so on for people of all ages as well. So very, very user-friendly. Again, for anybody who may be interested in the Cheshire and Mersey area, if you wanted to look at the criteria or part of the criteria that we use for referral, we use the FH Wales criteria. And basically, you can click on the link and go onto the form, enter the individual's details, and it will normally, or it should do, give you a score. And basically, for referral to the Cheshire and Mersey service, if an individual scores 6 or above, then they meet the criteria and they can come through our service. I mentioned before that if you ever do have a patient that you feel is just borderline, or you're not quite getting the score for them, by all means do contact us and we'll happily discuss rather than just a definite no. Okay. Recently, the Cheshire and Mersey service has been invited to the Northwest Genomics annual roadshow, and that included us going along and presenting a few different venues in the Northwest here. And I have to say, it was extremely enlightening, everything that is going on in the world of genetics. But the takeaway message that they want us to share with everybody is, with the likes of FH screening and so on, genetics is no longer a standalone, highly specialist field. Genetics is and will be in everyday healthcare by every practitioner out there. So every nurse, every doctor, every pharmacist. And I think we need to work together now to try and break down the barriers so that people do feel a lot more comfortable working with genetics, because hopefully, resources permitting, we will see a lot more of screening in genetics. And I was very thankful that they want us to emphasise that message about it being in everyday healthcare. And when I was discussing this with Marie, who presented earlier, and we were saying how wonderful it is to encourage genetics in everyday, to quote Marie, she said, yes, it's not weird science, it is everyday healthcare. So thank you for that little quote, Marie. So again, they're just the contact details for the Cheshire and Mersey FH service. If anybody wants to discuss anything or discuss any queries, or especially send any referrals to us, we'd be very grateful to you.